Hello, everyone. Thank you for joining today's webinar, Thinking Outside the Out-of-Network Box, New Options for Health Systems. This webinar is sponsored by Contigo Health. Contigo Health, a subsidiary of Premier, is a health benefits platform that leads direct-to-employer and direct-to-provider relationships that drive more affordable and appropriate care. Contigo Health is relentlessly focused on revolutionizing healthcare through cost-effective, transparent, comprehensive access, and thoughtful program design. At its core, Contigo Health ConfigureNet, with over 900,000 network providers across 4.1 million U.S. locations, helps improve access to care. ConfigureNet provides health plan payers and their health plan members medical claim savings through pre-negotiated discounts with network providers. ConfigureNet is differentiated by Contigo Health's high-performing benefits optimization products, including Sync Health Plan Administration, TPA, and Payvider solutions, and Centers of Excellence programs, including substance use disorders, cancer, and orthopedics. For more information, please visit contigohealth.com, as well as LinkedIn, YouTube, and Twitter. I'm Sean Edwards from Validation Institute. I'll be introducing our webinar today. Just a couple of quick announcements before we start. Due to the number of attendees, participant lines are muted. However, if you'd like to submit a question for our speakers, please do so using the Ask a Question box that you see on your screen. We'll answer all questions that we have time to address during our session today. Also, please note that this webinar is being recorded and you'll receive an email with a link to the video so that you can begin. Now I'd like to introduce our moderator for today. Josh Berlin is the CEO of Rule of Three. We are pleased to have him here. Josh, welcome. Thank you. Without further ado, I'm going to turn it over to you.
Thanks, Sean. Thanks to the Validation Institute, as well as the Contigo team and the Nebraska Health Network, the National Health Network. Lee, I'm already giving you a national network. The Nebraska Health Network for participating with us today. I'll have each of the panelists introduce themselves here in just a second, but it's certainly terrific to be able to spend some time thinking about, as healthcare is constantly changing around us as an industry and the ground seems to be shifting on a regular basis, there need to be a set of options that organizations, health systems particularly, can be focused on as in-network mixes effectively with out-of-network. We'll be spending some time on that topic, particularly today, but also hopefully providing an overview of what's happening in and across the industry, and as some context for the reasons why folks even need to be contemplating out-of-network as an option. So with that, why don't we go around the horn here just quickly with some intros. Robin, why don't we start with you, then Matthew, then Lee.
Hi, I'm Robin Buney from Contigo Health. I'm the Vice President of Network Product and Development.
Thanks, Robin.
Hi, I'm Matthew Malin. I'm the Senior Director of Network Operations for Contigo Health Plan.
Matthew.
Yeah, good morning, everyone. I'm Lee Handke. I'm the CEO of the Nebraska Health Network, which is an accountable care organization based in Omaha, and also the CEO of the Midwest Network Alliance, which is our direct-to-employer solution that we'll be talking a little bit more about today.
Well, thanks all three of you again for being here. Why don't we start with what's on so many folks' mind right now across the industry, not just health systems, but also employers as they're navigating a dynamic time for and on behalf of their employee population, certainly health plans as they're contemplating the continued evolution of their plan structures on behalf of their members, all the brokers and consultants that are out there thinking about the constantly shifting fiduciary landscape and beyond. So we've got lots of different activity happening. It's affecting all of us, particularly those of us who are consumers of healthcare, patients of healthcare, which is certainly what's at the center of where all the neat solutions ought to be focused on. So why don't we begin with what's happening and what's the state of things? Maybe Lee, if you don't mind kicking us off, just talking through in your mind, what are you seeing? What are the things that are affecting the Nebraska Health Network and all the constituents that you guys represent? Give us a landscape view of the industry.
Yeah, happy to do so, Josh. I think as probably in all the markets represented by the audience today, it's really still employers as a primary payer of healthcare services looking for affordable and high quality access for their employees and their dependents. They want to be assured that the plan that they put in front of those not only is competitive, but also can guide their employees and dependents to the best possible solutions. We've certainly seen that. I think, as everyone knows, value-based care is continuing to be at the forefront. Medicare, Medicaid, groups all rallying around that. I've seen that firsthand for the last 8 years as the leader of an accountable care organization here in the Omaha area. And so we have about 220,000 lives covered in those arrangements. And as employers started to hear of our efficiency and success in those programs, they naturally migrated to saying, how can we be a part of that? And how can we be a part of it in a more direct way, working directly with you as a health systems that's providing the care for the majority of our employees. I think as I think about how we work with some of the traditional insurers and payers, it's always kind of that arm's length relationship. Yes, we're working on quality and so forth, but we're not often at the table. And so I only give that background as kind of a little bit of background as we get to the networks and how those work and how in-network and out-of-network play together as a history to say that's the trend we're seeing is employers coming to us saying, how can we work directly? And it's been that way for probably the last 4 to 5 years. Nationally, we were seeing that gain traction. I think we can all think of probably conferences we've went to where employers employers and health systems have presented together about the success of those programs. The one that always jumps to my mind is what General Motors did with Henry Ford Health System directly. Mm-hmm. And I always think that's kind of ironic. General Motors working with Henry Ford.
It is ironic. I think they think it's ironic too.
I think probably, but the success that they saw in working directly with that network, the numbers I recall was about 17% reduction in PMPMs for them. That's a couple $1 million a month because they do that at scale. We had employers, I think, go to some of the same conferences, and then they came to us locally. We had one large employer saying, how can we duplicate that success with you? How can we look at how we build the network? How we look at putting discounts in place that would preference your providers, and in exchange for that, really raise quality for our dependents. And in our early model, what that resulted in was an in-network utilization rate that went from 60% to over 90%. So when that happens, you can afford to give better discounts. You can afford to look at how you structure the network to be in and out and tiered network relationships. But the thing that's most important for us, coming from an ACO background, is you have more of the data for that group that allows you to better manage their care. And so all those things coming together, a network, the discount, the quality, and how you promote care to stay in network through benefit design all comes into play and as is important there. So I think I'll leave comments just there as an introduction, but certainly would love to talk about how we structure the direct contracts, the wrap networks, and those sorts of things too, Josh.
Thanks, Lee. Appreciate it. Robin and Matthew, maybe we'll start with you through the Contigo lens. What are you guys seeing as some of the major challenges out there across the industry that folks you're interacting with seem to be dealing with or grappling with on a day-to-day basis?
I'm happy to start, Matt. In terms of Contigo and what we're seeing, as context, we are part of the Premier group. And so Premier has over 4,400 health systems as part of their group purchasing organizations, as well as many other offerings with Pink AI also. What we're hearing from health systems and also our Contigo customers, which the core are health systems as well, everybody's still trying to get back to pre-pandemic levels of care being offered, as well as staying on top of what the costs are with inflation. Everybody is trying to control costs, save costs, see what they can do. Also, as part of some of the implications of the pandemic, there's been a growth in out-of-area employees. So the pandemic got us all used to remote working. Employers have embraced that, health systems as well, and they have a far more significant number of employees that live outside of their core markets. From an employee benefit plan perspective for a health system, as well as if that health system happens to offer a provider-sponsored health plan, they see a higher volume of people out of area that they need to be in a position to both recruit, have valuable benefit package for them, and a lot of them are offering an in and out of network benefit. And on that out of network side, when a patient sees an out of network employee, or excuse me, an out of network provider, the cost associated with that is going to be much higher. And with wrap network offerings, it allows those employers to continue to offer that benefit, but to be able to access discounts and protections from balance billing that make that option more affordable. And those are some of the key trends that we've seen with the customers that we're working with.
That's helpful. Thanks, Robin. Matthew, what about you on your side of the world?
On the operations side, very similar to Robin. We still see, in working with our clients, the providers and their members, everyone struggles with cost. Everyone struggles with access, right? Ensuring that people are getting to it. And then you have to throw quality in there as well, right? So, every employer wants to provide their employees and their families access to quality care at an effective rate, and provide them with the access that they need to see the specialists and the providers that they want. So, as Robin said, the trend in the market today, because of the pandemic and the shift to more remote workforce, has taken your local network for a smaller self-funded plan and turned that into a much larger regional or national need. And that is where Contigo and other networks come into play to help that plan provide that access to the network that their membership needs.
Well, I think that's about as good as an overview as we could possibly have for all of the challenges that certainly the industry is that we're seeing across the industry as an advisory firm focused across the provider, plan, employer, and advocacy space. Certainly, all of that that each of you just described are areas that we're continuing to see our clients focused on across healthcare. But additionally, there are a number of innovative ways that organizations are grappling with all of the change and challenge that each of you just so eloquently described. Maybe highlight, if you don't mind, some of the more innovative practices that you're seeing your health system clients or customers think about, but also in your instance, Lee, and maybe we'll start with you again here, as an ACO that's owned by two health systems, but also having additionally created an employer-focused entity that has within it a number of provider organizations. What are some of the innovative things that you're seeing in the industry that led you to do led you to take some of the initiatives on that you have over the course of the last several months?
Yeah. Thanks, Josh. I think what I'll do is kind of jump off of where I left off and talk a little bit about the genesis of our direct-to-employer plan, which is called the Midwest Network Alliance, because within that, I think, comes some of the both the struggle and the solution to what we're faced with. So we had, like I said, a large employer come to us and say we wanted to do something direct. We launched that. It went very well. We saw good results. And within the course of the next year, we had 4 other employers or through their brokers consultant come to us directly and say, we want to do something similar. And so at that time, I went to our board and I said, these are wonderful opportunities. We need to embrace this new trend we're seeing in direct-to-employer and provider networks. But I think we need to be intentional versus reactive, because what we saw in that very first partnership we had is we were struggling to get good data out of the TPA and the system. And therefore, we were struggling to do our optimal job in doing care coordination quality programs. So that's when we said, let's come together, let's create a standard solution. So when an employer comes to us, we can have something. And we also said, I think this is bigger than just the Omaha market. It certainly, there's employers throughout our great state that are larger, self-funded, and there's other providers, I think, that have the same opportunities. And so that's when we decided to create a second organization that's actually owned by 7 health systems that work across the state. One of the things that I think we realize is one lesson is to know our place, know where we can provide value. For us, that's typically employers that have the preponderance of their employees based here within our state, because that's where we have the strongest direct network. But to what Robin and Matt both said is we're certainly seeing different trends in employers. We're seeing remote workforce. We're seeing, of course, kids going off to college and those sorts of things, and needing an opportunity to have that coverage in all 50 states. And so that's where we've partnered with WRAP Networks. And the way we do it is probably a little unique. We have a local WRAP partnership that we have with an organization that contracts and really focuses on Nebraska and Iowa. And so we partner with them for those two states exclusively because we think they know those markets and they do a pretty good job of understanding where they need to be from discount-wide perspective. And then in the other 48 states, we have another WRAP network. Sometimes we'll have large claims that occur within those networks that may be out of network, or that we want to say, let's go and do a direct agreement where we can get a better deal. And so we'll do a little bit of that as well. But the thing to note, and why a partner like Contigo is so important, I think, for provider organizations that want to have direct to employer approaches, is we have a pretty small, nimble team. And so while we can do a lot of the local direct contracting, which we've done here within the state, it wouldn't be worth our time, or we'd have the efficiency and scale to be able to do that on a national level. So that's where we've seen that. A couple innovative things, Josh, I think we do is whenever we enter a new market within our state, we sit down with that HR team, we get 18 months worth of claims. We see what claims and what percentage are hitting our direct network where we have the best discount. And then we see, are there providers that we want to add to that network? So to have a direct relationship versus our WRAP network where we can get a better discount. And so there's kind of interesting dynamic there, because a lot of our customers are actually health systems. And so sometimes it's like, yes, we'd like to add this provider to the network. And sometimes it's like, this is actually a provider that's not friendly with our health system that we'd like to just keep in the WRAP network, because we want to steer business into our direct network. So we do that on the front end. And then as they onboard onto our direct to employer platform, we look at that on an ongoing basis to see where the claims dollars are. We may want to add a provider after the fact, or we may want to do some outreach to those patients to get their care back within the network. So those are a couple innovative things we've done early on. I should note that we just launched our first employer group on January 1 of 2022. So we're just a year and a half into this. And so I think we continue to learn about how to best build that out for employees and their dependents.
Thanks, Lee. On the Contigo side, what are some of the more innovative things that you guys are seeing, either with the health systems you work with provider-sponsored health plans, and then also any direct-to-employer work that you guys are interacting with? What are some of the innovative practices that you guys are seeing out there, particularly anything that you're interacting with that has a total cost of care bent to it?
So Contigo has a number of direct-to-employer centers of excellence type solutions in place. We have recently brought to market a substance use disorder center of excellence program that has both a virtual as well as a bricks and mortar component. We have center of excellence programs in place with a number of large national employers. And in terms of the new SUD program in particular, we're seeing very good results relative to what can be done for the employee population to keep people, at work, productive, but getting the types of care that they need. And again, meeting the employee where they are by starting from a virtual perspective and getting help directly, and then moving towards, if you need to, have that more intense type care. Other centers of excellence products include bariatric surgery, musculoskeletal type services, and cancer care. And Contigo continues to see really good results with the employers that we work directly with on those programs.
Thanks, Robin. Matthew, you want to round that one out? And then we're starting to get some questions come in additionally too. So I'll start to filter some of those in. So thanks for folks who are submitting. Please continue to submit. What do you think on your side of the world, Matthew, some of the more innovative things you guys are seeing?
Sure. We're actually very similar to what Lee described in his network and network structure. Our TPA side of our business, we are seeing our networks become tiered in conjunction with benefit and benefit designs. So very similar, and trying to drive, especially in a health plan that is owned by a health system, right? Your intent, and you want to drive that care back into your own health system to prevent leakage to that kind of frenemy system that you might have in your marketplace. And so we are seeing the tiering of a network along with a benefit design structure that allows a member to make some choices, right, at a different cost and cost level, whether or not they want to continue and keep their care within their network and their system or seek care outside. And where Contigo kind of falls in is, you know, the domestic network. We have a regional wrap network that supports that network from expansion and needed services all the way to the out-of-network wrap to provide that broad coverage when needed. So very similar to what Lee's design is what we're seeing as a trend as well.
Matthew, why don't we take one of our first questions that got submitted? It's for you guys specifically, but given some of what Lee described earlier about the way that networks like where Lee is in Nebraska have tackled things like RAP and remote workforce options that each of you have highlighted, how does Contigo tackle that? Are those contracts that you guys own? Are you leasing contracts from others? What does that look like? And maybe, Matthew, stick with you if you don't mind, because it sort of builds off of one or two of the comments you just made.
Sure. So if we're working with an employer that is a health system and has a domestic network, obviously we start with that domestic network as the core, right? That's where you're driving and attempting to keep those services in a local market. Then we do very similar to what Lee has expressed as well, as we look and we do own our contracts as the network itself. So those were part of our acquisition that took place earlier or late last year in October. So those contracts are our own. They are direct contracts with those providers. We're not necessarily using a subleased network for our national out-of-network, to make sure I answer that. But building those networks really is a very similar process. I think most folks that are in the network business follow the same lead. So the first thing you look at is what Lee described, the disruption, right? Taking the historic utilization, comparing that to your network, and where do you have disruption that might occur to your members. So a good example is seeing a cardiologist. Patient saw a cardiologist multiple times. You can see that cardiologist was used, 10, 15 times out of network. If they're in your network, no disruption. If they're out of your network, you do have some disruption. The second piece to that is obviously looking at the shift in cost. What will the actual direct cost of care change from building that network and using a wrap network? And then lastly, it's the availability or the accessibility, right? Geographically, even though I may not have that existing cardiologist that was seen, do I have alternative providers? How quickly can someone see them? Is their panel open and available? And then ultimately, very similar, if we identify a large health system or a large provider in a specific need for the client, we would actually go out and do the contracting. We would actually be able to use that utilization and get a provider to participate, saying, hey, I can bring you as an in-network. You don't have to have the hassle to chase down the member for the money, do the balance billing. If you come in network, we can make with a reasonable level of reimbursement, make it easier for you, the plan, and the member.
Thanks so much. Lee, let's go back to you for a second. Maybe use, if you don't mind, the Midwest Network Alliance as a case study example and go a bit further where you were a minute ago when you introduced why you built the Midwest Network Alliance, what the purpose it served. But now that you've had some experience here since 1/1 of last year, what are you looking forward to? What meaningful outcomes are you aiming towards? Maybe talk about that for just a minute.
Yeah, happy to. It was kind of funny, Josh, when you slipped at the beginning and described us as the National Health Network, because it's almost...
I'm going to start calling you that all the time now.
Well, maybe that would come with a bigger job and salary and so forth, but it's almost the opposite.
It probably would.
It's the opposite of that is the benefit here, because we're hyper local. We know the providers. I used to work for a large payer in this market, so we had some good relationships, and others on my team really across the state. And one of the things we're just really trying to lean into when it comes to working with both the local health systems and the employers is the strength of those local ties. And a lot of the communities we're talking about here are, 50,000 residents or less. And so people know each other. They know each other through just local community activities. And so when we were working through some of the large payers, we knew that we cared for a lot of employees and dependents, but we were never at the table. It's almost like the providers were being used as the network, but all the meaningful interaction was happening between the payer and the employer and their employees. And so not only the 2 health systems here in Omaha that were part of our ACO, but also the other 5 that were part of the Midwest Network Alliance came to the table to say we can do better for our local partners, our local friends, our local families. I mean, because that's really how they viewed it. So I think some of the things that we're excited about is sitting down at the table to talk with those employers about what are the priorities, what does the data show, where do we have opportunities. I think something interesting, that Matt said was when you see someone using an out-of-network cardiologist 4, 5, 6, 7 times. Much the same can be said on the clinical side. When we see individuals struggling, maybe they're in the ER 4, 5, 6, 7, 8 times. Maybe there's behavioral health issues that surface. We see overutilization or underutilization of services. Then we can work directly with not just the primary care physicians in the care network, but also with the employer to say, let's identify what the issues are and how can we work better together, really leveraging what we learned on the accountable care organization side. The thing that I'm excited about is, as I said earlier, we're still pretty young in our data, and data is everything when it comes to really showing the proof of the promise of these direct-to-employer plans. It's not just simply a discount play. It's not a network access play. Those are all important, fundamental things that have to come here. But it's more the relationship and the outcomes and what you can do on the quality side that gets me most excited. And so as we have better longevity in these plans, I will say that we worked with a TPA partner that is, it's a single TPA choice. And so it's one platform. And the reason we like them a lot is they can get us that data. So we have claims data instantly. We also bring in our EMR data out of our health systems health records. And so we have kind of a complete picture of what that health looks like and opportunities look like for that population. So those are, I think, some of the exciting things that I would point out as we go down this path further.
Thanks, Lee. Hey, Robin, maybe a case study or two and that pops out in your mind, if you don't mind sharing it with us, given all of the significant factors that you highlighted earlier and that we've now talked through a bit that are facing organizations around the country. What's an organizational example or two that you think is just really doing this well, and for that matter, has embraced the notion of out of network and how successful you can be without out of network becoming a punitive thing?
I would say directionally, the types of things that we've seen are obviously where employees end up choosing to go out of network, that we're able to assist them in finding a provider that we have a contract in place with. And those providers, we have a relationship with, we work with, the employee is able also to be protected from balance billing, which we think is a unique position with our contracts. There are lots of health plans that might in their summary plan description say, this is the basis that we'll calculate the out-of-network reimbursement that we'll use. But in those instances, the member isn't protected. They're still subject to a provider possibly balance billing them up to charge. Where our contracts, it's a negotiated rate, and our providers have agreed to accept it as payment in full, and the member is not subject to any additional balance billing, which is a great situation for a member or patient that ends up deciding to seek care out of network.
Thanks so much. Matthew, why don't we go to you with one of the other questions that we've had submitted to. This is through the lens of an independent or individual physician. The notion of distinct workflows often comes up when a physician is having to tackle, particularly a sole practitioner or small practice, is having to tackle how do they need to be thinking about a patient that's covered through traditional means versus a patient that's covered by some type of employer direct network. Are there best practices that perhaps you could highlight that the independent physician out there can be thinking about?
One thing, Matt, I was thinking about that you and I have talked about many times over is we believe that physicians are used to looking at the back of the member's ID card and calling the plan to find out, what the rules are that they need to be following. So I don't necessarily think they do something unique between those two use cases. Basically, call the plan, find out what the employee benefits are, what the pre-authorization type requirements are, and make sure that they're following what they need to give the employee the best coverage as well as for themselves to ensure payment and prompt payment to follow what those rules are. But Matt, I don't know. Sorry, I jumped in. I don't know if you would add to that.
I think, Robin, yes, you're absolutely right. Right. When you're dealing with a network provider, you have that patient. Obviously, the clinical consideration comes first. So that's why I paused, because I want to make sure that, from a physician's lens, you need to do what's right for the patient. The network comes secondary. So it should be a conversation between the physician and that patient that, hey, I'd like you to see physician ABC. Are they in your network? You might want to check with your health plan, right? Where Robin is saying follow those rules. And guiding a patient to the care that they need, that's probably is the key, right? Is there an authorization requirement for you to go and see someone out of network, right? Those typically in health plan benefit designs, require, and the onus is put on to the patient to make sure they obtain that authorization. But that physician's practice, as a best practice, may say, we'll pick up the phone and call on your behalf, make sure that we get you in to see Dr. Smith, who may or may not be in your network. So I think understanding your patient population, your health plans that you work with routinely, what their requirements are operationally for pre-certifications, approvals for out-of-network, utilizing a member services department, utilizing a provider services department is probably the best practice that they could follow. Again, first thing first, patient care.
So some tools, some technique. Lee, how have you guys handled that here in your early going? Although I hesitate to still call it early because you guys have done such an immense amount of work to get things up and running. But how have you tackled this kind of issue?
Yeah, I like how Jennifer worded the question, because it's kind of like the image I get is what's going on in the provider's mind as far as their clinical workflow and all the responsibilities there, and then trying to figure out with these new networks that are often narrow or tiered, how do they navigate that? What we hear from physicians a lot of time is, you're asking me to do one more thing. I already have limited time with patients, and now you want us to do, and let's use some clinical examples. You want me to increase my number of annual wellness visits. You want me to increase my code recapture, because that's what the Medicare Advantage plans want me to do. You want me to, close care gaps across our populations. And so I think if we're relying on the physicians and, maybe that direct clinical team to understand all these variations of the network, we've probably lost. Because they have a lot of other things going on. And so I think, to pick up on something Matthew said, is we really want to put that power and knowledge in the hands of the consumer. And, we have some nice tools that are digital and online and apps and things that clearly delineate that network. But I think probably the most effective way is a good old-fashioned conversation to be available at the time of enrollment. And so we always make sure, and this is kind of the old-fashioned thing, but that we're on site, that our TPA is on site. We have individuals on site, because the first question I think a lot of people ask when they go to a narrow network or to a tiered or high-performance network is my provider in the network? Okay, check that box, yes or no, we get that. And so if we can be there at the time of enrollment, both initially and then at follow-up times to kind of guide and help them answer those questions, then at the point where they're talking to their physician about maybe it's a referral decision or maybe it's a, some in-network, out-of-network decision they have to make, and how does my benefit compare to that they'll be armed with that information to help it go better. And certainly I think, our physician and their support staff is very good about helping with those things. But if we can make it more efficient by informing the member, then I think that's probably the best approach.
Hey, Robin, how much of an actual dedicated out-of-network strategy do organizations need to have? Is it, in your mind, is it something that requires focus, attention, some level of rigidity? Is it if you're doing this correctly, if you're building your network correctly, is it something that really should just become part and parcel with how you develop your overall network strategy? What does that look like for organizations that Contigo works with?
Well, what Matt talked about a little bit earlier, and Lee as well, when it comes to a health system's employee benefit plan, and if they are a provider-sponsored health plan, the core focus is in their area, their core market, and building out the network, for their local market where they're going to offer their employee benefit plan and or their health plan in that market. But when you get to the place that you're offering a PPO that has in and out of network benefits, then you have to address what you're going to do, both locally from an out of network perspective as well as out of area. And so, those health systems and how they design that and what they want to do, that having a network strategy in place, having a cost containment strategy for that out of network benefit is really important. And today, with everyone looking for, potential savings, looking at that strategy is a low-hanging fruit type of an activity. Do we have a wrap network in place to help us from that cost containment perspective? And if we do have one in place, is it getting us where we need to be relative to the savings that we would like to achieve?
Matthew, I'm going to reference another question that we've gotten in, and maybe through your operational lens, comment for a minute on how things that come up that have some regulatory implication you see playing out when you guys are working closely with your clients and customers, things like surprise billing, the limit on out-of-pocket cost sharing, maybe other examples that you see that are prevalent. What does that look like when this really gets executed effectively?
Sure. Probably the biggest change is the impact to the the No Surprises Act, right, and how that impacts the network and a member seeking, emergent care. The nice thing about using a wrap network is that you do have a contract with a provider, which eliminates the need to follow some of the No Surprises Act rules, in particular looking at pricing that needs to occur based upon a regional or national level, based upon what is the fair price to be paid to the provider for services. Since you have a contract and the provider's under contract and you're using that network to access that contract, you can eliminate that. Again, our contracts with the balanced billing prevents that member from being billed for the services very similar to the No Surprises Act. So that regulatory requirement in the network is probably one of the biggest things that we have seen have an impact on us. So as the health plan is building its network, they're looking at their No Surprises Act and their requirements to meet that, where a member is seeking that care that falls into those services. There is the ability to help control that to a degree.
Lee, when you guys have structured your benefits within the network, does it overcome some of the regulatory hurdles, or for that matter, take advantage of any of the loophole areas that can certainly bring member benefit?
Yeah, maybe before we go, there's just back to Linda's question on how we're treating our providers just in general within the tiering. So we actually, in our direct network agreement, we have a provision within that contract that guarantees that those directly contracted providers will be at a lower tier than both a wrap network provider and an out-of-network provider. And the reason we structured that is that gives them some benefit of steerage within the network. Therefore, we have better discounts that we can garner and a better partnership as far as when we're working on clinical initiatives. There's other provisions within that contract that they'll share data with us, that they'll participate in our clinical quality programs and those sorts of things. So it kind of creates that very collegial relationship. Back to your question a little bit about on the benefit side. So from a basic tiering structure, we've allowed employers to, most of them have done 3 or 4 tier benefits so far. And within that direct network, you can do a domestic tier if you are a health provider employer group. So you may want to direct steerage to your own provider. Then you'd have our direct tier, then out of network, then wrap, and then out of network. So in that case, it'd be a 4-tier plan. Others have chosen to use the entire direct network as tier 1 in that. Now, the nice thing about benefit design is we have experts in the market. I think there's probably a lot of them on the call today in the audience, and those are our very trusted consultants and brokers that come alongside our employer plan. We've decided that we'll never sell direct. We're not the experts in that. We can promote what we're doing, but we're always going to go back to that employer's trusted consultant or broker to help them structure what that benefit should look like. And so we have some opinions on where we like that to be, but certainly we can trust them, their legal team, and the employers already have great relationships there. So we want to bolster what they do and hopefully provide them with another very solid option as it comes to looking at employee benefits and what they might advise their clients to do.
Robin, maybe let's go to you next for a continued out-of-network question here. How much fluidity do you see with folks moving in and out of network, and maybe some of the implications there as well? If you've got an out-of-network claim, but now suddenly the subsequent claims become something that's a bit more in-network, maybe some of the cost and savings considerations there.
What I would say, particularly when you take urgent and emergent claims out of the mix, oftentimes the out-of-network decision by a member, a patient, has to do with maybe they have a long-standing relationship, whether it's with a primary care physician, an OB-GYN, or some type of specialist. And oftentimes employees will say, I have this relationship, I still want to see them. But if they have an event that causes them to need a procedure or any kind of care, that more expensive care, say hospital-based care, then they're going to want to make sure that that care is delivered from in-network providers. And then the onus is on the patient to keep their out-of-network provider in the loop, if you will. They certainly could seek to get, we'll just say, a knee replacement out of network, but the member cost sharing from a deductible, co-insurance, and out-of-pocket max, that it's going to be a more limited base of employees that can afford to, if you will, self-insure that out-of-network care. And so I see the out-of-network utilization more, it's based on preference of who you want to see, and the lower cost type services give them that flexibility. But for sure, when it is a more complex level of care needed, it's in the patient's best interest, definitely, to be seeking in-network providers.
Lee, when you guys have worked through some of the analysis on your side, are there common triggers? Robin's highlighted a few different types of care. Are there common triggers or common access elements that you see appearing when you guys have looked across your member base?
Yeah, I think a lot of what we see, I mean, we're pretty good, Josh, when it comes to in-state or regional coverage. And that's because of the strength of both our direct network, but also our local wrap partner because they do, they've been around for many years and have good relationships throughout as well. I think the ones we see pop up are some of the high dollar out of state cases. And that could be both from a wrap perspective or out of network perspective. Maybe someone is traveling to a different region, could be as a result of a recommendation of their local team, or maybe, as you hear word of mouth, as cancer centers are probably a big one that we see pop up there. And I know Contigo does a lot of work and it's been very successful in some of their single case agreements and the work there. We've done some similar things just directly here. We have someone that's full-time working on contracting the network and network relationships and done some of that. But those are probably the big dollar ones that we see pop up a little bit.
Thanks, Lee. Hey, Matthew, let me come to you next for just pull this thread a little bit further. As you're tackling, or as you guys are seeing some of the critical negotiation tactics that you could advise organizations around, what are some of the ins and outs that you guys typically recommend for organizations to be considering, try to head some of this stuff off at the pass before it even happens?
So obviously the first two pieces are, making sure that as a health plan, you're designing your benefit and your benefit structure to drive the patient where you want to go. That goes hand in hand with your network structure, right? When that fails, now you're in right, you have a provider who is not in your network, a member who needs services, and what do you do, right? That's typically where you can utilize services of the network to say, hey, we want you to go out and negotiate this single case agreement with this provider on our behalf. Or you then turn it over to your network team, right? And that becomes a single case agreement that's negotiated particular to that member and to that provider for, an acute service. When it comes to tactics there, really as a health system and working with the provider, obviously, you're looking for the win-win here for everyone, right? You want the win for the provider or the member first and foremost, just to be able to obtain the services that they're seeking and have those covered as an in-network benefit. Second, you are working with a provider and you're helping the provider out in that, one, you're negotiating a fair and reasonable rate in good faith for that service. You are also giving them the ability, rather than that health plan paying a member directly for those covered out-of-network services and or them chasing money, they know they're going to get paid by you and paid by you timely. And so there's a benefit to the provider there. And then obviously to the health plan, right, you're able to negotiate, hopefully, a reasonable discount that you would not have otherwise obtained if you just let it hit the out-of-network benefits. So to me, it's about looking for that win-win-win, right, and coming up with that reasonable single case agreement. But there is, at that point, when it's gone through your benefit structure, it's gone through your network structure, you're in that single case.
Helpful, thanks. Maybe take that a little bit further, and then Lee, I want to get your perspective here too. Then we'll open it up to the rest of the Q&A. Sean will take us through. We got a second part of a question that had previously been asked by Linda. Do you treat the ACA limit on out-of-pocket cost sharing as applicable to services by providers in the RAP network? How do you tackle that, Matthew?
So because we don't, as the network, we don't actually adjudicate claims to a member's benefit, right? That would fall back to that TPA and or that administrator and how they've set up those out-of-network benefits to be processed. Now, typically when you're using a network or a network provider, if you are applying in-network benefits, it would never hit that limit, right? So based on your benefit design, if it flows to an out-of-network benefit, obviously then you're adjudicating and you're looking at those limitations in cost sharing and making those adjustments to any pricing that would occur when you adjudicate the claim. Unfortunately, Contigo as a network, we don't adjudicate those claims. So I can't answer that directly.
For our plans, Josh, I think the out-of-pocket applies to in-network utilization of essential health benefits, and the cap's like $9,100, if I'm recalling correctly. I believe our plans are the direct network and the wrap network. So we do consider the wrap network to be in network because it's really an extension of our network. And so both the direct and the wrap network would apply to that.
Perfect. Thanks so much. Hey, Sean, why don't I hand it over to you and you track some of these questions for us, if you don't mind.
Great, thank you. First question, what key performance attributes should you look for when comparing wrap networks?
Lee, maybe that's a good one for you to start with, particularly since the formation of the network is relatively recent, but also there was a lot of negotiation on how to develop the wrap network and what are some of the metrics you and your team are looking to drive towards.
Yeah, I mean, for us, Josh, honestly, it was breadth and access. We knew that we had limited time to put together a full network that would serve the needs of these employers, and it's pretty easy to contract with the PHOs, which will get you a majority of your physicians, professionals, and hospital services. But then when you think about all the behavioral health providers, OT, PT, Chiro, and a lot of the ancillary services, that becomes very cumbersome and tedious to be able to develop that robust wrap network. So it's great to have organizations like Contigo and others that have done that heavy lifting. So you can focus on where will the majority of the claims hit, how do I get a direct network with a very aggressive discount there, and then how can I rely on my partners to give me the rest of that breadth. So that's kind of how we looked at it. So we evaluated those networks. Certainly, we looked at efficiency and history of how accurately and quickly claims are processed and some of those things. But for us, job one was building a robust network, using them as a partner.
Thanks, Lee. Hey, Robin, on your side, what are some of the key performance attributes that, as you guys work with health systems around the country, that you're typically seeing endorsed or asked for?
From a performance perspective, it's going to be it's all about the cost. So what kind of savings are you driving? What kind of par rate? How many participating providers do you have that particular employee benefit plan needs? And certainly they look for disruption as well. So how many, what's the matching on your network compared to a network I might be with today? Some of that, you have to look at where's the density of that care and how many cardiologists do you need in a region, and maybe in a given region, one wrap network has 15, your wrap network also has 15, it's just a different 15. And, then you can look to quality indicators to say, does one network perform better than the other? Is the quality of those providers better potentially? So again, access, disruption, as well as savings that are being driven as a result of how that network performs.
Yeah, I think, Josh, if I can follow up really quick, because Robin reminded me of something when she said par rate and talked a little bit about the rates. And some people may say, well, I'm surprised, Lee didn't mention something about competitive discounts versus the breadth of the network. And I'm a core negotiator. That's what I did for a large payer in this market. So I know those rates. But for us, when we think of the wrap network, we're hoping that we're driving 90 to 95% of the services in network. And so that becomes more the importance. The wrap network really then is less about the discount, which we still hope is competitive, and we're pretty comfortable that folks like Contigo are doing their due diligence there, but it's less about that because really we're hoping to use it for a small percentage of the claims.
Got it. Sean?
What are the impacts to health plan administrators when changing from one wrap network to another?
Well, that's a good one. Matthew, you want to kick us off there?
I think they are the same three items that we are talking about now, right? So first and foremost is cost, right? So looking at one network compared to the other, what is your cost of care, and how is that going to change? The second piece is the access and availability of the network, right? Are you providing the same or similar coverage to your employees that you had? Again, you may not have the same physicians, but you'll have the same coverage, as Robin indicated. And then third is really looking at that discount or that disruption, right? If I move networks, right, how much do my networks match? If I have a 98% match and it's only 2% of my membership that is going to be impacted, am I willing to make this move? Versus if only 75% match, right, and 25% of those people are impacted, is a very different decision. Even if the cost is far greater, right, and the access does exist, do you want to disrupt that much of your membership? So I think those three things still come into play as an administrator looking at switching networks, whether that's a primary network or a wrap network. In either of those, all three are the same.
Lee, you want to round that out with anything in practice that you guys have seen?
Yeah, I think Matt hit on three of the key ones from a wrap perspective. The one I would probably add when it comes to the administration side is, we partner with the TPA on the claims processing, whether that's in network or sending those claims to a wrap network to be repriced and sent back. And so again, it's important for us to be able to work with a wrap network that can bring the data back as well, because if we only had claims from our direct network, we're missing some key factors. And so just as they're integrating a new wrap network, to make sure those connections are built, they're efficient, and they're reliable.
Got it. Sean, do we have time for one more? We need to tackle some closing comments. What do you think?
I think we can squeeze in one more. I've got a question for Robin. What metrics do you use to measure provider quality indicators?
We use a national tool, and it's baked into the tool in terms of cost and quality, and we rely on the metrics that were developed based on that national data, leveraging a tool that we use for the network measurement.
Got it. Okay, in the interest of time, I think it would be great if we could have all of you participants give closing thoughts.
Robin, you want to start us out since
happy to do so. Yes, for sure. I'll go back to, we definitely agree that when it comes to a health plan, benefit plan design, the domestic network is key, and driving utilization of your domestic network is definitely going to be the first and primary importance for that both health plan as well as their employees. When it comes then though to offering out of network, it's looking at what options are available. Do you have something in place? Are you managing every aspect of cost that you can to drive the most efficient employee benefit plan or health plan offering that you can?
Matthew?
Sure. Closing comments, I would think for anyone looking to truly think outside of the network box, all right, take a look at, what we've talked about, those three key indicators in your network. So as Robin said, it starts with your benefit design. It then works your way into your network and your network structure and how you do that. And then lastly, as Lee has mentioned, right, how do you administer that plan and that network going forward? All three of those are key to coming up with a solution that is unique and different, that meets the needs of the population you serve.
Thanks, Matthew. Lee, bring us home.
Yeah, I think, just sharing some stats from a National Business Group on Health study from last year, Josh, I remember about 25% or about a fourth of employers are looking to contract directly with integrated health delivery systems for benefits. Another stat they said there is in 10 years time, this is going to be the most dominant structure for employer provided benefits. It strikes me that employers have been used to broad networks with great coverage, whether that be through the Blues, United, Aetna, or others. We can't throw out products that don't offer that same experience. And so it's just so important, I think, to be able to not just work locally, but also with wraps. So employers don't have that thud when they move to that and say, this isn't what I used to have. It's got to be robust. And we're thankful for organizations like Contigo and others that are helping us along that path.
Thanks, Lee. And just to pull that thread one bit further to close us out, that same survey highlights that now significant embrace that large employers, including health systems around the country, have for integrating workforce health and well-being strategies into what they're overall tackling for their employees across their organization. So the importance of what we've talked about today and all of the elements in it are certainly part and parcel with that. And it's been terrific to spend time with Robin, Matthew, and Lee and thinking about not just the potential for out-of-network activities, but overall what your network strategy can really bring to your employee populations. Thanks so much, everyone, for spending some time.
Thank you.
Welcome.
Thank you, everyone. Thanks to our speakers. Thank you to our sponsor, Contigo Health, for making this session possible today. Just a reminder, everyone, the webinar has been recorded, and you'll receive an email with a link to the video so that you can view it again. Thanks again for joining us, everyone. Have a great day. And this now concludes today's session.